Associate Director of the Institute for Public Policy and Social Research at Michigan State University. And along with our partners at the MSU Institute for Health Policy, we're pleased to bring you today this session on Health Policy Issues Group. Just a few notes, this is being recorded, and you will please ask questions through the Q&A box. Kathy Stifler and I will be monitoring those. The chat box has been disabled, as has the raised hand function for today. Kathy, if I'm missing anything, please fill in. Want to thank our sponsors, funders of this event, the Michigan Health Endowment Fund. And with that, I'll turn it over to my partner, Kathy Stifler with the MSU Institute for Health Policy.
Thank you, Arnold, and welcome. Thank you for joining us this morning. We are very pleased to offer this session today that was frequently requested by legislative leaders around this very important but often confusing topic of pharmacy pricing. There's a great amount of interest around this area, including a lot of legislative activity. And we wanted to provide some foundational information to help everyone understand and sort of level set around this topic that truly is confusing for everybody. And we're so pleased today to have two true experts in the field to help us work through this session today. I'll start by introducing Doug Brown. Doug is the Senior Vice President of Value and Access at COEUS Consulting Group. He has 30 years of pharmacy management experience, the last 18 years working with Magellan RX, where his focus was on government markets, working to address strategies that help operational efficiency and stakeholder value in Medicaid. He worked with many states in that role, many state Medicaid agencies in that role, including Michigan, where he began at the call center serving Michigan pharmaceutical Medicaid issues since 2002. Doug also provided subject matter expertise to federal and state legislation that impacted state Medicaid programs. And of keynote is he developed the foundation for an outcomes-based contracting program in Medicaid with the intent of pivoting drug pricing discussion away from unit cost toward focusing more on total cost of care. So Doug will begin our presentation today. And they will be going back and forth. So I'm going to introduce our second speaker as well, and that's Carrie Germain. Carrie is a registered pharmacist and the Senior Director for Performance Improvement and Management of HEDIS, Medicaid Stars and Reporting for the Health Alliance Plan in Michigan. She has diverse pharmacy experience, including community practice, managed care, and prescription benefit management. For more than 25 years, she provided strategic leadership for all aspects of the Health Plus in-house pharmacy benefit management program. Carrie had also chaired Michigan Medicaid's Drug Utilization Review Board until March of this year. She had been the chair for 5 years before that and served on the DOR for over 13 years. And according to her forever, she has also chaired the Michigan Association of Health Plans Pharmacy Directors Committee. So I am going to now turn it over to Doug, and I will be managing the questions as we go. There will be logical breaks, and I will take that time to field the questions that come in through the Q&A. So Doug, take it away.
Great, thank you, Kathy. I appreciate the introduction. Can you hear me okay? Great. So it's a pleasure to be here, be with you all this morning. I've enjoyed getting prepped here for this meeting with Carrie and meeting Carrie. Together, we, the challenge with any presentation of this caliber is it's difficult sometimes to understand the background that everyone has, and we want to make sure that there's something in this presentation for everyone. So the way we've designed the presentation, we'll start with that foundational background of Medicaid, and then build upon that foundation the pharmacy issues and the pharmacy landscape. So you understand where we came from and how we got to kind of where we are today. And with that in mind, Carrie and I both worked hard to tailor the presentation to an audience that perhaps has different levels of understanding here, so that the hope is that everyone will come away with some understanding or some new understanding of pharmacy. From that perspective, I will provide more of a national view, and Carrie will provide more of a local Michigan-focused view of the market from there. The last piece that I have before we jump into the presentation is I'll be referencing the Magellan Medicaid Trend Report, which I was the executive sponsor for a number of years. So you'll see a couple of slides from that presentation in the deck today, but that's where the background for that is. Carrie, anything you want to jump in and say at this point before we jump into the presentation?
No, not at this point, Doug, other than I'll echo what you said. I really enjoyed working with you on this project, and hopefully folks will find this as useful tools going forward as they're meeting with some of their constituents.
Great. Okay. Arnold, do you want to share back the screen with me, and then we'll get this kicked off?
You should be able to share the screen again, Doug.
Okay.
So.
All right, let me grab that here. Okay. And just confirm that you can see the title slide.
Yes.
Okay, great. All right. So let's talk through the agenda and where we want to go over the next hour or so. So we're going to start with this high-level overview, as I stated coming in just a second ago. We'll start with a high-level Medicaid program overview. We'll look at state funding and federal funding for the Medicaid program, and then we'll look at the pharmacy delivery for Medicaid as it exists today. We'll take a look at national trends, and then I'll spend some time talking about, as we kind of get to that point where we really focus on pharmacy, and talk about the Medicaid drug rebate program and the origins of that, how the calculations are done, and the rebates inside that program, and the net cost pricing that goes along with the Medicaid program. Then as we pivot, we're going to go to Carrie, who's going to talk a little bit about an overview of Part D and some of the questions legislators may get from constituents there. We'll talk about PBM tools, network agreements, pharmacy audits, and get into some details around that. And we'll end talking a little bit about spread pricing and pass-through pricing models. Finally, we're going to be talking about a lot of terms in this presentation, and we've included a glossary in the back, so you can look up some of the terms. We'll try to talk about them as we go through, but in the back, there's 2.5 slides that kind of list out definitions. Those definitions in that glossary pertain to this presentation, so kind of tailored those definitions so that they fit with this presentation. There may be other things, and you may want to do additional research on those definitions if there's other questions that you have after this. Okay. All right, so let's jump in and talk about the Medicaid pharmacy program from an overview. From the very highest level, Medicaid is the second largest budget item that states have behind primary and secondary education. No surprise to probably anyone on the call here today. Medicaid provides coverage for 70 to 80 million Americans, low-income adults, children, pregnant women, elderly adults, and people with disabilities. Program is funded jointly by the state and the federal government, and the oversight of the Medicaid program falls under the Centers for Medicare and Medicaid Services, also known as CMS. Medicaid is administered by states, but they have to follow the guidelines that are put in place by the federal government. And Medicaid is commonly delivered in states as either a fee-for-service program, where the state pays providers directly for the services that are received by beneficiaries, under a managed care organization, or MCO, in which the state provides patient care through case management, in this case, through a capitated arrangement, which provides budget predictability. And then you may find where you're doing it through a combination of fee-for-service and MCOs, where you have that, and that's very common across states. We'll get to a national slide later on in the deck that kind of shows where different states are in that regard. From a governing body, essentially, we have on the left side, you start with federal law, rules and regs, and then federal policy and sub-regulatory guidance. CMS provides these guidance, provides the rules and regulations then, and makes the rules and regulations and provides guidance to both manufacturers and to states as to how to operationalize the rules and regulations that the federal law provides for. On the state side, you've got state laws, rules and regs, and then policy and sub-regulatory guidance. State law subordinate to federal law. And then those rules and regulations, you take the CMS guidance and then you tailor your program in Michigan to best fit the beneficiaries in the program that you all want within the construct that CMS and within the guidance that CMS provides for under the program. From a funding standpoint, Medicaid is funded by a combination of both federal and state dollars, as I said before. Federal financial participation, FFP, is the state's, in a state's Medicaid program is based on per capita income within those states. So the higher the per capita income, the lower the federal match is essentially. But poorer states get higher match and higher dollars. That FFP is expressed as a percentage known as Federal Medicaid Assistance Percentage, or FMAP. And we'll look at the FMAP on the next slide and what that looks like for each state as we go across. Important to note that the FMAP is set at a minimum discount. The feds participate at a 50% rate, and it's capped at 83%. So the bullet point at the bottom here, in fiscal year 2021, regular FMAP ranges for 50% for New York and 12 high-income states, and up to 77% for the lowest income state, Mississippi. Now, because of COVID and some other things and the public health emergency, Congress allocated an additional 6.2% made available to all states during COVID and the public health emergency. So for the most part, best of my knowledge, all states accepted that. One of the strings attached or the criteria in place was that the states could not disenroll anyone from Medicaid, but they got an extra 6.2%. So states like New York and others are now at 56.2%. Mississippi is now over 80% on their federal matching funds. Here's the graphic. This was off the CMS website for state fiscal year 2021. Michigan is here in this column here and rides at about 63%. And then you would have that additional FMAP, emergency FMAP, that puts you about 70%. So the 70 cents on the dollar for this program comes from federal funding. That's the bottom line and short story here. As we move now, we talk about service delivery. Service delivery in states is provided under two basic arrangements, a Medicaid MCO and a fee-for-service model. And Carrie, the Medicaid MCOs in Michigan are called health plans. What's the right term for it?
MHP might be a term that people are familiar with, managed health plan.
Managed health plan, okay. In this deck, you're gonna see it as MCO, but in Michigan, again, managed health plan. And in this slide, we wanna kind of highlight some of the differences between the two programs. On the left with the MCOs, MCOs accept a capitated reimbursement on a per beneficiary basis. And they are at risk for both medical and pharmacy drug spend. So also under this model, and in Michigan where you have a single preferred drug list now, the MCOs or their PBM will use similar utilization metrics or prior authorization programs that mirror, in this case, the fee-for-service programs. In other states, they'll have their own. If they're not under a single preferred drug list program, they will have their own criteria for managing their pharmacy program. Reimbursements on the MCO side are generally tied to a percentage of wholesale acquisition cost, the price that pharmacies can buy drugs for from a wholesaler, or that manufacturers sell their drug to the wholesaler, or an average wholesale price methodology. So a percentage of that plus a dispensing fee that can range from 50 cents up to about $3. Many of the MCOs and their corresponding PBMs will use a narrow provider network as a cost containment measure, meaning the more you trade volume, the more people would use your pharmacy, the lower the deeper the discount would be for that. And then MCOs use PBMs to administer the pharmacy benefit. On the fee-for-service side, state Medicaid programs manage to a legislative appropriation. Fee-for-service, it utilizes a prior authorization process to ensure compliance to the preferred drug list and clinical appropriateness of other drugs. In Michigan, you've got not only a preferred drug list, but you also have the MPPL that has the preferred list for drugs beyond the preferred drug list. The reimbursement for pharmacies is done through NADAC, the National Average Drug Acquisition Cost Model. This is a program that CMS manages, takes the average cost of drugs from across the country, sets this national average cost that is supposed to more accurately reflect the actual prices paid by pharmacies for drugs. And then to potentially offset a lower reimbursement, NADAC is coupled with what's called a professional dispensing fee. Generally, this professional dispensing fee is $10 to $12. And I think in Michigan, you have a professional dispensing fee that may be between $7 and $12, depending on generic and brand, and then a $20 dispensing fee for specialty drugs. And then the state uses any willing provider network. So any provider that wants to use or use the NADAC as their reimbursement is free to participate. We see that across the country. And that states in their fee-for-service programs contract with pharmacy benefit administrators to administer the pharmacy benefit. Now, the next slide, we'll talk about the differences between a PBA and a PBM. So basic differences here are really in the first bullet on both sides. So on the left, a PBM is funded, funding is provided by the state and under a capitated rate set through an actuarially sound process. So you understand what you take risk, you take other elements, and you put that all in, and it all gets baked into that capitated rate. On the PBA side, the state contracts with a pharmacy benefit administrator to manage the pharmacy benefit under a fixed fee contract, but the state is at risk for total drug spend. So the PBA in that case manages the benefit, but they manage it at the benefit at the direction of the state. Back on the PBM side, what you see is the PBM is at risk for total drug spend. And as a result, there's administrative fees under a capitated model that are significant that the MCOs get compensated for to manage this and to take risk in this management. And this model provides budget predictability. So it's kind of like insurance. You're buying insurance to get that budget predictability. You're paying this administrative cost, or the state pays this administrative cost as part of that cap rate in that process. And the numbers can be significant, millions or hundreds of millions of dollars in this administrative fee bucket to ensure that budget predictability. On the PBA side, this model from the state Medicaid staff retains all the decision-making authority, and the PBA just administers the program as the state directs them, and the state's responsible for state staff are responsible for managing it within the budget appropriation within each state's budget. Important to note that a PBA and a PBM use the same tools: preferred drug list, prior authorization. The reimbursement, of course, is going to be different, as I pointed out. But many of the tools that you use, call center, things like that, they're the same in both places. It's just the payment arrangement to each entity that is different in these arrangements. Okay. So let's move on and talk about the national trends that we see that we've seen in the market over the past couple of years. And then we have a map that follows this one, a slide that follows this one. It shows what's happening nationwide. So from a policy perspective, legislatures are being faced with, what we hear in the market is this lack of financial transparency in the market, provider dissatisfaction with MCOs and PBMs. And it's forcing state legislatures to take a look at who should manage the pharmacy benefit. And pharmacists prefer the Medicaid reimbursement algorithm of NADAC to kind of that commercial reimbursement plans because of the higher dispensing rates. Physicians prefer a single prior authorization process and a single preferred drug list for ease of management with their patient loads for Medicaid beneficiaries. And spread pricing is perceived as a benefit to PBMs at the expense of pharmacies and taxpayers. But there's reasons behind spread pricing, and we're going to address that as we get further on, and go into a little more detail around that and the reasons behind spread pricing. But as a result, legislators around the country are looking at spread pricing. They're addressing these issues by eliminating spread pricing, moving to single preferred drug list programs, or carving the pharmacy benefit out of MCOs altogether. Okay, and let's take a look now at what, we look at this from a global perspective, and we look at it nationwide. Global is not the right word. Nationwide, right? This is what it looks like today from states that have the states that are purple have their management of pharmacy is in the fee-for-service program, where it's carved out of the MCOs. The yellow or orange, depending upon how you're seeing this, those states have a unified preferred drug list, where MCO and the fee-for-service program share the same formulary. And then you have blue states where the MCOs control their own pharmacy network, and the fee-for-service program controls its own pharmacy network. And there's 3 states in here that have a partial unified PDL, or they manage 10 to 20 classes, and then the rest of the classes are managed independently by the MCOs and by the fee-for-service programs. If we wind the clock back to the Affordable Care Act, in 2011, with the Affordable Care Act, Congress allowed and mandated that states collect federal rebates on managed care utilization. Prior to that, that utilization was not eligible for federal rebate. In 2011, it became eligible for federal rebate, and we saw the pendulum kind of swing, and the pharmacy benefit moved out to a number of MCOs, because the states felt that they were still getting those rebates, and those plans could manage that. And we saw that this real, the map was much bluer in 2011. In 2013, Texas moved to this position where they unified the PDL based on the rebates, and the additional rebate they could collect by managing the benefit themselves. Florida was soon to follow, and we've seen a number of states kind of come over, and recently we've seen Delaware and Pennsylvania and Kentucky last year. Michigan, I think, early this year, came over to have a single PDL. California and New York, both interestingly, have had plans in place to move from this separate MCO and fee-for-service model right to carving the benefit out of MCOs and bringing it all into the fee-for-service model. Now, California was expected to go earlier this year. There was a merger between an MCO and their current point of sale vendor. They need to get through that first to make sure there's no conflicts of interest, and then they anticipate going right now, perhaps by July of 2021. New York was scheduled to go in April of this year and move over that direction. Then it was pushed back to May. Since the governor in New York has had some issues, this has now been pushed back for 2 years, and it's scheduled to go in April of 2023. Okay. So I want to move now and pivot and really kind of talk about the Medicaid pharmacy program, called the Medicaid Drug Rebate Program, and talk about the history of the program, where pharmacy pricing is, and give that background. So if we wind the clock back, and this time we're going all the way back to 1990. So in 1990, this Medicaid Drug Rebate Program was established. Prior to that, or at that time, Medicaid was paying more for drugs than commercial plans. And Congress looked for a remedy for that. They introduced, as part of this, 3 key elements to ensure that Medicaid always got the best price that was available in the market. And they established these 3 items. First, a minimum discount for brand and generic drugs. Then they added a consumer price index that protects the states against inflation on inflation pricing. And finally, this number 3, they established best price as a component of the rebate calculation to ensure that Medicaid could receive the same discount that the most efficient purchasers in the market were receiving. CVS Caremark, Magellan, Prime, Humana, Kaiser, doesn't matter. Whatever the deepest discount that a manufacturer would give to a commercial entity automatically comes to Medicaid in the program. The pricing in Medicaid is protected from public disclosure, but is available to states. So the state folks that handle the rebates, the state folks that handle pharmacy pricing, they can all see this, but you can't make it public. And there's the federal site where the protection lies. And then participation in the Medicaid drug rebate program by manufacturers is voluntary, but it includes all of their drugs. So a manufacturer can't say, I want to participate with this drug, but not this one. It's their whole. They're either all in or they're all out in the program. So I mentioned earlier about the Medicaid drug rebate, the Medicaid trend report. This is one of the slides from that, one of the graphics from that. And in the Medicaid drug rebate program, when we look at it from a very high level, and the level of rebate that we get that states get in the program, the average federal rebate in the program was 54.6% in 2019. Now you can look at this little graphic in two ways. You can look at it as a percentage of brand and generic. In other words, generics have a rebate based on reimbursement at about 11%, and brands are about 63%. So brands are 63% because of that CPI penalty. Most of the discount is driven by that CPI penalty. And we'll get to the formula here in just a minute, actually on the next slide. We'll talk about what that formula looks like to generate that discount of brands that way. We can also look at this as specialty and traditional drugs. So traditional drugs have a rebate of about 61%. You can see how it mimics the brands in a large way. But specialty drugs, newer to the market, start with a lower a federal rebate, some CPI penalty in there, but they have a lower federal rebate. And when you average generic and especially in traditional drugs, you're averaging, either way you look at this, it's about 54.6%. Supplemental rebates. So states will negotiate supplemental rebates just like commercial plans do. 47 states today have a preferred drug list and look for supplemental rebates to get additional discounts for manufacturers in competitive therapeutic classes. Together, we're looking at a discount of about 60 cents on the dollar for states, federal and supplemental. 100% of those dollars for both federal and supplemental rebates are paid to the state. And then those rebates are then shared with the federal government according to the state's FMAP percentage, or federal matching funds percentage. Today, the federal rebate is capped at 100% of the average manufacturer price. When the ACA expanded coverage so that they could get rebates on MCO utilization, they also increased the base rebate from 15.1% to 23.1%. That 8% increase, when they put that in, they had to put a cap of 100% of AMP into the system because a number of manufacturers, their federal rebate would exceed the prices paid for the drug by the state. And so they put that cap in. Now, if you paid attention and to the recent legislation in Congress with the last COVID Relief Act and Relief Bill, Congress is going to remove the cap in 2024. This will generate billions of dollars for states and the federal government in drugs that exceed the cap that today are capped. There is a caution here that you could have some manufacturers where some of their products or a majority of their products exceed the cap, and you potentially could run the risk that manufacturers would drop out of the Medicaid drug rebate program. So there may be some additional factors that go into this as we get closer to 24, where they may ratchet this down to 125% or 150% to put some kind of cap on that, because some manufacturers could be overexposed on this and then end up pulling out of the Medicaid drug rebate system or program. I mentioned that we were going to talk about the calculation of drugs and how we calculate, or how the federal government calculates the rebates. But first, I want to make sure that folks understand that the rebates in Medicaid are mandatory, right? In order to get the federal funding, states must invoice for the federally mandated rebate. So Medicaid isn't chasing rebates in the sense that just trying to chase rebates to that is a bad thing. I mean, they're mandatorily required to collect rebates on a regular basis, on a quarterly basis. So the calculation for brand drugs today is 23.1% of average manufacturer price, or it's the average manufacturer price minus the best price. And whichever one is greater to that, then you add the CPI penalty. And the CPI penalty, again, is if the manufacturer raises their rate faster than the rate of inflation, that difference comes back to the states in the form of an additional rebate on top of this piece. So for a small subset of drugs, clotting factors in drugs used exclusively for pediatrics, the rebate is 17.1%. The rest of the formula is the same. And generic drugs, it's 13% of the average manufacturer price plus CPI penalty. Okay. Let's see, these points at the bottom we've already talked about. States, again, must collect these invoices because this is how Medicaid, this is how the federal government is helping to fund the Medicaid program is through these rebates. Here's an example of how the calculus works inside this rebate. So in this illustrative example, we have an average manufacturer's price of $100. We have a best price of $60. Let's say that the commercial entity, one of the ones I just mentioned, was able to negotiate a price point at $60 off of this $100 price point. And then we have a CPI penalty of $20. So CPI penalty, manufacturer raised their rate raised their rate at 10% over the last 5 years. The CPI was 1.5 or 2%. That percentage increase over time equals $20 in this example. So we do the math that here's the formula we saw on the last. So we calculate this as 23.1% of AMP. AMP is $100, so it's $23.10. Or it's AMP minus best price. $100 minus $60 is $40. So we take the larger of those numbers, in this case it's $40, and then we add to that the $20 CPI penalty, and we end up with a federal rebate of $60. So the net cost to the state in this example is $100, which is what they essentially paid for the product, minus a $60 rebate equals a $40 net cost to the state. Okay. Remember, commercial plans can get to this best price piece in here, but Medicaid is always going to get, at a minimum, they're going to get the same best price that commercial plans negotiate, but that CPI penalty often drives a deeper discount here. And we know from history, most manufacturers are taking price increases that exceed the rate of inflation. Okay. In this graphic, what we do is we try to illustrate what happens over the life of a product when it comes in and when a product is introduced into the market. And then on the y-axis, we have price for that product. And on the x-axis, we have time. And so we look at this product as it comes in and it's a new product to market through its patent expiration, which occurs in this hash line going north and south. And then generics are available after this. And the illustration here is really around the pharmacy economics within the Medicaid space. And it gets to brand over generic or brand and generic pricing, which we're going to talk about in the next slide. But in this example, we're going to say that at product launch, the drug costs $100. And for simplicity, the AWP, the WAC, the AMP is all $100. And so on day one, when the product comes to market, the 23.1% of AMP is $23.10. So that establishes the federal rebate on day one. Now, this product in this example comes into a competitive therapeutic class. There are 3 other drugs that do exactly the same thing. In order for the manufacturer to have their drug on the preferred drug list, competitive class, they have to offer a supplemental rebate. Supplemental rebates ride on top of federal rebates. And in Medicaid, supplemental rebates are best price exempt. So they don't impact this best price number. The best price number is on the commercial side, not in the Medicaid space. So what happens then is, as this manufacturer puts in their federal rebate plus their $27 supplemental rebate to get to a price point of $50, the state's net cost rides in this difference here. This green line is the state's net cost of this drug. So they pay $100 for the drug, but they get $50 back in federal and supplemental rebates. Through time, we see the federal rebate continue to increase because of CPI penalty, because of contracting in the market with commercial vendors. And right as we get close to patent expiration, the manufacturer takes price increases, rapid price increases, to squeeze out as many dollars as they can as they get right till their patent expires. And we see a spike in the CPI penalty, and the federal rebate also spikes. So the price to the state of a brand name drug becomes very small, okay? And what happens is at the time you cross over the patent expiration line, this price might be, in this illustrative example, might be $150. And then a generic that would come to the market might be priced at, let's say, $130. And so for commercial plans, this is a welcome piece, right? You've got a $20 discount. You'll take advantage of that. Commercial plans will have a new generic to put on a generic copay. Brands will be moved from a second to a third tier, and you'll start promoting the generic. For Medicaid, that product comes out at $130. The federal rebate is 13% of AMP, or average manufacturer price, and there's a CPI penalty, but there's no CPI penalty in the first year of this product, actually in the first 5 quarters, because the CPI isn't established until the 5th full quarter for generics, because generics are deflationary in nature, meaning you have one that comes out initially and then multiple generics follow, and that price begins to decline through time. And so initially when the generic comes out, the cost of that generic is very expensive, could be $100 in this example. So you're comparing a $100 generic to a $30 brand or a $20 brand, depending on what the gap is here at the time of patent expiration. Okay, and that leads us to this discussion about preferring brands over generics. So we know that that generic utilization rates in managed Medicaid plans is higher than the fee-for-service plans. And it's generally in the high 80s, low 90s, and Medicaid runs in the mid 80s, right? In the Medicaid trend report, it was 86% last year. But one of the primary differences here is this accounting for new to market generics. Now, we have, observers often criticize the Medicaid program as being inefficient for preferring more higher cost brands than lower cost generics. But many times it has to do with the federal accounting, the accounting of brand name drugs, net of federal rebates, and it's often less expensive than new to market generics. Now, there's a number of states that not only have a preferred drug list that has these branded products preferred and generics non-preferred, but some states published a list. New York, for example, publishes a list just isolating these preferred brand drugs, and to use those brand drugs instead of the generic solely based on net of federal pricing. And last year, we saw in the Medicaid trend report that states that were in the report, 26 states that were reported in that report, saved $320 million by preferring brand over generic drugs, or an average of $70 per claim. So the numbers are substantive here, right? And so that's the global view of kind of what's happening from a high level. I'm going to go to Carrie now, and Carrie, I know that in this next slide, you're going to start with this brand over generic, and then you're going to get into some of the other stuff. And I'm going to turn it over to Hugh, and I'll keep driving the slides here.
Thank you, Doug. Great overview. Just to give you kind of a background of what's happened here in Michigan, prior to the transition from a common formulary that was developed in collaboration with the health plans in Michigan, the managed health plans, and the department, the Medicaid department, they then transitioned to the PDL this last fall, October 1st, 2020. So the health plans looked together at the common formulary opportunity. I just want to give a little background there. They looked at the formulary list, the step therapy and prior authorization guidelines that Doug mentioned, and I'll talk a little bit more about. And then additionally, they looked at quantity limits, gender edits, whether it should be used by males, females, age edits, those types of things. And prior to the PDL, health plans had preferred generics over brand formulary medications. But the health plans in the common formulary were not allowed to be more restricted than the common formulary. They could be less restrictive, however. They could choose to not have an edit that was restrictive and remove that. Health plans have done a great job of transitioning their members to the PDL since October of 2020. That requires the health plans to then identify people who are using drugs different than they were on the common formulary, and then to give them an opportunity to transition, communicate with their provider. They've done a great job there. So what has happened as a result of the PDL is that the money that's paid out to the pharmacies for brands where previously generics were available or preferred is higher, and that requires capitation rate adjustments to be made. Additionally, pharmacy providers may be concerned, and you may hear from them, as the PDL drugs are more expensive than the previously preferred generics that were on the managed health plan formularies or the common health common formulary, and that increases the pharmacy's inventory costs and can reduce the margins on the brand drugs versus the generics that they dispense. So just want to lay that out there. That's what's been going on in Michigan over the last year or so. So what I'm going to do, as Doug mentioned, is I'm not going to go in depth in the Medicare Part D drug program, but because it's very complex, but I just want to give you a kind of an overview because you may be getting questions from constituents, and also talk about some of the commercial pricing considerations that we need to share because you may get questions. And I think one of the things that I can maybe leave you today is when someone does approach you with questions, is to maybe ask them what kind of coverage that they have. Because as you can see, Medicaid is much different than Medicare, and it will be different than commercial. However, they do have some common tools that are used to manage those programs. So starting with the Medicare Part D prescription drug program, you may be familiar with the donut hole. So we'll start with what this program looks like. Medicare Part D prescription program is a voluntary outpatient program that is provided by private health plans. And you might hear PDP, which is a prescription drug program only, or MAPD, which is where the person gets their prescription and medical programs from the same payer. There's 4 phases to this program, and it starts with a deductible of this year, which every year this amount is adjusted for all of these phases. It's $0 to $445 in the deductible, where the person will pay the full cost of their prescription. And then in the initial phase, they start to pay a copayment or a co-insurance out of pocket until that drug cost total reaches $4,130. So next year, that might be about $4,300. And then the coverage gap, which is commonly known as the donut hole here, you'll see that the person then falls into what they call the hole, where they're paying 25% of the cost of the prescription. And that can be pretty considerable. And then once they go through that $6,550, they go into a catastrophic phase where they're paying a much lower copayment, or they're paying 5% of the cost, whichever is less. So this is what might bring someone to your office asking questions or not understanding, but I just wanted to share it. And then additionally, some of the medications that you're probably familiar with that will put persons through this gap coverage into catastrophic are medications like insulin, where it could be up to a $900 cost a month. And if they get three months at a time, that's a considerable amount of money, and it will take them very close to that coverage gap. Additionally, specialty medications might be Enbrel, Humira, used for rheumatoid arthritis. Those medications cost about $7,000 a month, and that'll put a person into and through the coverage gap pretty quickly. So their out-of-pocket costs will actually vary pretty considerably, and it might drive them to come and ask you questions. So you can see the complexity, and this is only the prescription program benefit part. There's a lot of regulations that go with it as well. Okay, so this is one of my favorites, and I'm hoping that you'll find this to be a useful tool as people are asking you questions, or if you're going to understand the background of what the U.S. pharmacy distribution looks like of medications, and then how they're paid for. So I'll start with the manufacturer. If you look at the product movement line, which is the blue line, the manufacturer is obviously creating the medication, gets FDA approval, sets the price, and then starts selling the medication. The drug wholesaler on the left is the one who's purchasing the medication. So the manufacturer is providing it to the wholesaler. The wholesaler will then increase the charge of that medication because they're providing a service. They're then contracting with the pharmacy who is providing the medication to the patient. The pharmacy may have an agreement with the wholesaler as a prime vendor agreement, which means they probably purchase about 90% of their medications from that single drug wholesaler. Then if you look at the red lines, which are the contractual relationships, each of these handoffs require a contract to be in place. The PBMs, which are on the right, will contract with the manufacturers who develop the medication for the rebates and the formulary preference that Doug described. And then they contract with the pharmacy providers for reimbursement and services, and they contract with third-party payers for services that they provide. So you can see this all becomes very complex. And then the green lines, which are the financial relationships, are the money that's exchanged for the products and the services. And what's really not represented here are the specialty pharmacies that Doug referenced that may distribute the medications like the Enbrel and the Humira. And those are may have special relationships with the manufacturers who could be owned by the PBMs, specialty pharmacies, or they could contract directly with the health plan or the payer. So you can see this is all very complex, but it gives you kind of a flow of the contract, the service, the product. Go ahead, Doug. So these are some of the tools that are used pretty universally across what Doug talked about. And so they might apply to the Medicaid program, the Medicare program, and to commercial business being that is contracted by the health plan or the third-party payer with maybe a purchaser. So for example, I have John's Auto Garage, and I'm going to contract with them for services for pharmacy benefits. And so we will determine what the cost of that service looks like, what the benefit will look like, what John is willing to pay for the service. And then it will be decided what kind of benefit and co-payments, for example, the person will have. And behind all of those negotiations are the pharmacy benefit tools that you see here. So the PBM is using these tools to, they negotiate the agreements with the pharmacies. So the retail pharmacy, which you're familiar with, it could be John's Pharmacy, it could be Walgreens or CVS. And then there are mail order pharmacies, which may be providing 3 months at a time, more convenient, less cost, and then the specialty pharmacies that I just referenced. So in general, for a commercial prescription drug plan formularies, the generics are preferred, unlike what Doug just described, where they're going to more of a brand product focus, where they can get the rebates and then the generics. And then that's followed by the therapeutically similar preferred brands that are available. Generic drug pricing is controlled through the maximum allowable cost programs that are in place, and MAC pricing programs. And then brand product cost is determined by the payments that are negotiated with pharmacy providers. And then preferred brand drug placement on a formulary is supported by the rebates that are negotiated with manufacturers that Doug talked about, which is similar across all of those types of coverage that I talked about, Medicare, Medicaid, and commercial business. So how do these pieces fit together? The PBMs and the payers implement step therapy and prior authorization programs, mainly to promote generics first and appropriate use of preferred brands. And then it reduces the cost and enhances the safety of the benefit and the medications that people are getting, and make sure that they have the appropriate medications. The drug utilization review programs that result in relationships with the pharmacy benefit managers, that reduces the waste and there can be overuse of medications. There can also be underuse of medications. And then we don't want people to get duplication, suffer adverse events. So it's an important function as a relationship of a health plan to a PBM. And then they implement those quality programs that are identified through the drug utilization review process to improve medication adherence, make sure the person has the right drug at the right place at the right time. Go ahead, Doug.
Should be on the next slide now.
Sure. So as a subset of what I just shared with the tools, the pharmacy network agreements can have a variety of items included in it, but what's really important is it defines the drug product reimbursement that Doug talked about, the dispensing fees that the pharmacy is paid. It also defines the billing requirements, what the pharmacy needs to do, what they need to submit, how they will be paid, when they'll be paid. It also talks about service expectations that the health plan or the pharmacy benefit manager has of that pharmacy that's participating. And then it does also include a definition of the audit guidelines that a pharmacy is subject to if they agree to participate in the program. And I know Doug talked a little bit about the open versus preferred or narrow networks. These became a little bit more popular back in 2010, 2011 with Medicare Part D, where it became important to narrow the number of pharmacies that were receiving reimbursement from that health plan. And in exchange for being in a preferred network, they actually took a lower reimbursement rate, but they were getting a preference so that they'd have a higher volume of customers, if you will, in their pharmacies. That doesn't exclude other pharmacies necessarily. It just means they might get the regular rate, but the person that's coming to their pharmacy might have to pay a higher copayment. So they don't get the advantage of the higher volume. So that's a strategy that PBMs use to help additionally control the cost where they have some high volume. You can go ahead. All right, so talking about the pharmacy provider audits, and I would imagine that some of the folks in the state who are providing pharmacy services may have contacted offices about this. So the purpose of pharmacy audits, and they are very important, is to allow the PBMs and the payers and health plans to ensure that the contracts that have been signed and the regulatory rules are being followed. And so pharmacies need to make sure that they're agreeing or understand what they're agreeing to when they sign a network agreement. It also helps to reduce fraud, waste, and abuse. And so we want to make sure that pharmacies are honest and providing great services, which the majority of them are, and then containing the healthcare costs for purchasers and consumers. We want to make sure that the bills that are coming to a PBM on behalf of a payer are accurate and that they're not using it as a way to increase their revenue. And I'm not saying that pharmacies do that because, the majority, as I said, are following the rules of engagement. The types of audit that you might see are the desktop audits, and this is kind of the preliminary. The pharmacy will be asked for prescription copies and maybe ask for patient signature logs to prove that the person actually picked it up. Those audits can actually result in a further audit, an on-site audit, where the pharmacy is notified of the audit with a list of claims and signature logs for review. And generally, the pharmacies are given an advance notice for that audit. The on-sites may include requests for the manufacturer invoices to support that they actually purchased the medication. And that becomes very important too. The types of things that they're looking for is aberrant claims. So they'll look for, where instances where pharmacies are submitting claims that are outside of the trend for other pharmacies. So it might be opioids, for example, high cost medications, compounded claims. And so that might prompt an on-site audit. The reason I mentioned that they normally get a notice is because that is the norm. In my experience, I was involved in 2 different cases where our auditor was sent to a pharmacy without notice because there was obvious evidence of fraud. And as we were walking they were walking in the front of the pharmacy, they were taking tubs of the prescriptions out to their car and putting it in the trunk so that they couldn't be audited, which they were, and eventually terminated from our network. But the other one was a pharmacy that we sent an auditor to, 2 auditors, one to the front door, one to the back door. As they entered the front door, the owner left the back door to avoid an audit. We ultimately audited that pharmacy and were able to remove them from the network. In both cases, significant fraud was occurring. So that's the reason why there may be limited notice, but it is rare. And then there are instances where pharmacy claims might be coming through the pharmacy system, but they may be held and reviewed for appropriateness before the pharmacy actually receives the dollars that have been committed through the claims transaction. And then finally, the triggers. As I mentioned, you might have some unusual claims patterns, unusually high number of prescription types. You could even see when they're sending in the claims. They might be sending them at night and when the pharmacy is not even open. And then we watched for regulatory sanctions, actions on licenses. And then it's very important when we used to get reports from patients or providers that were complaining about pharmacies' unusual activity. And then, as I mentioned, after the audit, they'll get a pharmacy report of the findings. And then there may be an opportunity or a reason for the pharmacy to want to appeal those findings and then produce some documentation. The audit may result in financial recovery, it may not, and that will differ based on the agreement between the PBM and the payer. And then this is something that Doug referenced. And so this is spread versus pass-through pricing. Just wanted to kind of give you an overview of what it is and what it means. So in your conversations with pharmacy providers and others, you might hear these terms. So the spread pricing can be allowed or prevented by the contracts that we sign with pharmacies, and that's based on the payer or the PBM. And then a pharmacy can purchase a drug from a wholesaler. Go back to your big slide, and then maybe $10, and then they dispense it to a patient. They send a claim to the pharmacy benefit manager through the claim system, and they get $12. So the PBM pays the pharmacy $12 and turns around and bills the payer or the health plan for that claim at $20, and then they keep the $8 or the spread. Michigan Medicaid no longer allows Medicaid health plans to have spread pricing terms in their PBM contracts, but there are other arrangements that between payers and PBMs that are outside of Medicaid that may have spread pricing. So pass-through pricing conversely occurs when the pricing that's paid to the PBM is also charged to the payer. So in this example, the $10 paid to the pharmacy is also charged to the payer. And I think with that, we're going to questions.
At the moment, we have no questions. Any questions can be put in the Q&A function now if there are any questions from our participants.
I want to comment while we're waiting for any questions to come in. I want to make one comment back about brand and generics, just so folks understand. In the Medicaid programs, generally Medicaid programs use the brand over generic judiciously. In other words, there may be states average maybe 20 drugs to maybe 40 drugs on their brand over generic program. It isn't like hundreds of drugs that they're preferring the brand drug instead of the generic. It's usually isolated to high volume drugs where the savings is going to reach a threshold that's going to be significant. And the difference between the cost of the brand and generic is significant. So it does impact pharmacies. The higher carrying cost, it does impact plans because the reimbursements are higher. But it is limited to some degree to 20 or up to 40, branded products at any one time. Okay.
Thanks, Doug.
Yeah.
A question has come in, and it's specific to the difference between open networks and preferred or narrow networks. You have covered it, but they'd like you to go over that one more time. And honestly, this is often a question that has come up during my time in the state Medicaid program from legislators with their constituents. There's often concern that are brought to their legislators. So it would be helpful if either of you or both of you could address this perhaps in a little more detail.
Carrie?
Sure. So I'm not really sure where to start, but the goal is to reduce the overall cost, obviously, for the payer, also for the consumer. So to reduce the cost for the consumer, which is usually their co-payment or co-insurance, you look for ways to reduce the amount of money that's being paid to the folks that are providing the service. And they agree to do this. This is, part of the choice that they make. And as I mentioned, if a chain pharmacy, for example, chooses to take a lower reimbursement in an exchange, they are getting the preference or the preferred status attached to their pharmacy. That will drive folks with that lower copay to their pharmacy. That doesn't mean they can't visit another pharmacy in the network. And there are requirements, especially for Medicare, that you have to have so many pharmacies within a certain radius of where that patient lives. But they can choose to go to a more local pharmacy, independent pharmacy, or a chain that doesn't participate in the preferred network. They will, however, have to pay that higher copayment. The pharmacy that doesn't participate in the preferred network may get a higher reimbursement rate, but they won't get the volume of folks that are coming to their pharmacy because of the lower copayment.
Carrie, could you address the Medicaid access requirements in the case of a narrow network?
So are you saying specifically, Kathy?
Yeah, do you mind?
I don't know that I know the exact access at this point. I've been out of that for a little bit. So I'm not really sure what your question is.
So the last I knew, and perhaps someone from the Medicaid agency that are on could confirm with me, but the last I knew was still 30 minutes, 30-mile requirement. So if they couldn't narrow the network more than that, that would force someone to travel more than 30 minutes or 30 miles. And I will wait to hear I will confirm that one way or the other with folks.
And similarly within Medicare Part D plans, there will be a radius, and there's urban and rural numbers that plans have to follow. So again, you have to have an adequate network to serve the population.
Correct. And from the state perspective, the contract between the state and the Medicaid health plans lays out the requirements for access, and access is probably the single most important component of that contract, is perhaps equal to quality, but that access is available for the Medicaid members. Any other questions? Oh, so let's talk about spread pricing for a minute. When spread pricing is prohibited, are there often corresponding administrative cost increases by the pharmacy benefit manager? It's probably for you, Doug.
Well,
but either of you.
I mean, and I'm out on a limb because let me answer the question this way and just say, this is caveated because I'm not 100% sure, but if you remove one of the tools in spread, such as spread pricing, because the state has to pays the MCOs using an actuarially sound model, because of CMS determines that it has to be an actuarially sound model, then if you remove spread pricing as one of the pieces that lowers costs, then the other costs are going to have to increase in order to make sure that the plan can stay whole inside that new rate. So the rate would be elevated and you remove that spread pricing piece. That's about as far as I can go on and talk about spread pricing, because spread pricing doesn't occur in a fee-for-service environment.
Carrie G, is there anything you wanted to add on that?
No, I don't.
Any other questions? Are either of you aware of changes with the relatively new Biden administration around this topic? Are there things coming down the pike specific to policy initiatives by the Biden administration?
You know, there's a number of policies that were promoted by Trump right at the end of the year. One of those had to do with value-based purchasing arrangements, and then specifically in Medicaid, a line extension provision that may impact states and the decisions that they make around some of their products. Value-based contracting is something that is very of high interest to me. One of the challenges for manufacturers around value-based purchasing has always been that a single patient failure could reset a manufacturer's best price, which would then be made available to all of Medicaid. And so manufacturers were somewhat reluctant to engage in those types of arrangements. Under the final rule, which I believe the Biden administration put on hold and then released, so it will go into effect on January 1st, 2022. Under the value-based rule, manufacturers can now, under prescribed conditions, can isolate those value-based contracts and the best price within those contracts by using a bundled sale methodology, which is a long way of saying, you can protect your bottom line, or a manufacturer can protect their bottom line because of, as long as their value-based contract their value-based contract meets certain prescribed definitions by CMS. The hope is that CMS has said, we hope this will allow these types of arrangements to then move into Medicaid more easily and be in the Medicaid space, so that they can move away from a volume-based discounting or rebate per unit discounting and more toward a value-based arrangement where the value of the drug is being assessed on how well patients do on the drug, not on just the volume of number of drugs that a patient or plan uses and takes. So it's an interesting piece as it moves forward. That's the one I've had my eye on, but I'm sure there's lots of other things that the Biden administration is looking at.
Thanks, Doug.
Yep.
And from Trish Bauk, from the pharmacy director at the department, there is a difference between rural and urban access. So 25 minutes, 25 miles for non-rural versus 30 minutes, 30 miles for rural. are the requirements in the contract for access in those narrow networks. So the network cannot be more narrow than would allow for those requirements for beneficiaries to access a pharmacy. Now, having said that, there are times when they could walk to a pharmacy before the network was narrowed and then would need access to transportation once a network became narrow that still met the contract requirements, but then would require the beneficiary or your constituents to then have transportation. But as a reminder, while challenging, Medicaid does, the Medicaid health plans and do offer transportation assistance, as does the fee-for-service program. Any other questions? Thank you, Trish, for that. Anybody else? Arnold, is there anything you want to add at the end here? We'll give everybody a few minutes back in their day if there's anything to add.
Well, I want to thank our presenters, Doug and Carrie, for taking time on what is a complex and complicated issue with many elements to it. So as Michigan policymakers move forward with legislation to reduce pharmacy drug costs, I think we'd all be wise to understand that it's not easy at all. So I want to thank Doug and Carrie. If there are no other questions, Kathy, we can end a few minutes early. And to the group, we are putting together an agenda for our next session. The slides have been posted on our resource page, and we will get that out to the group in the next day or two, along with the video of today's presentation. So thank you again to everyone, and have a great rest of your week.
I will second the thank you to Carrie and Doug. I really appreciated your availability, your hard work to present this complex information in a simple way, well, as simple as it can be made. And thank you so much for your assistance today. And for those folks that were able to participate today, thank you. And we hope that those who are able to view it through the recording, also, please feel free to let us know if you have questions that you weren't able to ask them today. So thank you all.
Thank you.
Thank you.
Thank you. Yep. Thanks, Kathy.